Today's talk will be on the perioperative pain management for the pediatric urologist. I'm Dennis Liu. I'm an assistant professor of urology at Lurie Children's Hospital and Northwestern University Feinberg School of Medicine. So welcome to the talk. Feel free to jump in with any questions while we go over this, and hopefully you guys will find this interesting. So to start, oops, let's see, I want to advance. So there we go. Okay, so I have no disclosures, and I don't plan to discuss any off-label uses to my knowledge. So it is the timing comes in quite well. September is actually the Pain Awareness Month over at Lurie Children's Hospital. And I think that this really brings up a topic that we don't necessarily get exposure to during our training. As we know that proper pain management is a very important aspect of the perioperative pediatric anesthesia care. A lot of times we depend on our pediatric anesthesiologist colleagues to manage this part of it. But I think a good working knowledge for the pediatric urologist is vital to know what they're doing and to help contribute to patient and parent satisfaction. So the story about pain and pain management is actually a quite interesting and slightly controversial topic. As you guys must have heard, pain has been been touted as the fifth vital sign. And from the history of this started in 1990 with an editorial that was printed in the Annals of Internal Medicine by Dr. Max Mitchell, who was the chair of the American Pain Society, bringing to attention a lack of pain assessment tools and the lack of treatment that he saw of pain in medicine. This sort of spurned legislatures to get involved, starting with California, which then made it an essential component of a healthcare licensure to have to document and assess a patient's pain scale just as much as a vital sign, sort of incorporating pain as the fifth vital sign. And it went to so far as the Joint Commission in 2000 rolling this into their standard of healthcare organizations and touting this as being essential to a good healthcare facility and one of the requirements to be in good standings. But what were the unintended consequences of this? Of course, pain management is an essential part of it. By putting these legislative mandates on it, however, what they've caused is a steep increase in opioid prescriptions. So again, if you look at this time frame in the graph, around 2000, 1999, 2000 is when you started to get pain as a fifth vital sign. And as you can see, an incremental growth in prescriptions of both oxycodone as well as hydrocodone. And this has subsequently also led to overdose. And this is a scale from the National Vital Statistics that shows opioid overdose deaths. As you can see, there's always a lag. You have an increase in opioid prescriptions, and you can see that the number and the rates of deaths have climbed steadily ever since pain has been associated with the fifth vital sign. So I think in this talk, we're going to focus on non-opioid options for the management of perioperative pain. I'd like to try to recognize some of the safety principles associated with regional anesthetic blocks, identify the various neuraxial and peripheral blocks that are commonly used in pediatric urology, and then dive into the literature to see if they have proven efficacies, as well as potential concerns and controversies regarding these regional blocks. And then also to familiarize yourselves with some of the techniques in performing some pediatric urology relevant peripheral blocks, so you can do these on your own. So to start off with, there are several advantages, known advantages or recognized advantages of neuraxial or peripheral nerve blocks. One is that it provides superior analgesia. The thought is that you can blunt the hormone response during intraoperatively, and because of this, the anesthesiologist would have to use less amounts of opioid to control pain while in the perioperative period. It's a useful adjunct to general anesthesia by itself, not just for pain, but allows the anesthesiologist to use less anesthetics during the procedure, allowing for a more rapid and smoother emergence from general anesthesia. In patients, this has been associated with an earlier return of appetite. By also avoiding opioids, they do have a quicker recovery from their GI function. And there's a question that you can possibly use this to alleviate the concerns regarding anesthetic neurotoxicity. So why is it important for the pediatric urologist to know this information? Well, in this study by Morrison et al., 2014, they surveyed members of the SPU in 7 case scenarios of common pediatric urology cases. And what they found is, if you look at this table here, is that there is no consensus in terms of what is proper pain management for each of these procedures, ranging from the simple of a circumcision to the more inpatient-oriented bilateral ureteral reimplants and pyeloplasty. What is also important to recognize is that when pediatric urologists answered that they did use, or that local or regional blocks were used for postoperative pain control, 53% of these blocks stated, or 53% of the respondents said that they performed the blocks themselves, and another additional 19 state that either them or the anesthesiologist perform the blocks, and therefore it's important to learn these techniques. All right, so one of the first things to sort of go over is what kind of agents are available to us to use for local anesthetics. Probably the most recognized and common one is bupivacaine. Bupivacaine is also known as Marcaine. It has quick onset and good pain relief. The anesthesiologists tend to favor ropivacaine. Ropivacaine also has similar onset times as bupivacaine. The benefits is that the duration, it has a lower risk of CNS and cardiac toxicity, while still maintaining the same duration of action, similar to even some stating that it could last longer than Marcaine. So when you know these two common agents, the other important thing to know is how much can you use, because there is recognized toxicity with local anesthetics. And so this is a table that shows the maximum allowable dosage of bupivacaine, sorry about that, bupivacaine as well as ropivacaine, the most common usage, both as a single dose and as a continuous infusion. The most important thing to remember about maximum allowable doses is that the toxicity of local anesthetics are additive. So with each block, if you use on the same patient, you have to account for that individual agent in an additive process. So the effects of local anesthetic is also important and reliant on the concentration. So it's not just the dosage itself, but it's the concentration. And so when you get the local anesthetic, it's also often given to you as a percentage. And so 1% equals 10 milligrams per ml. It has been known that lower concentrations of local anesthetics are probably better and safer in younger children. And therefore, you tend to favor 0.25% bupivacaine when you use in real practice for infants and smaller children. In older patients, you can then expand that to 0.5%. Higher concentrations of local anesthetics do have longer durations of action, so there is some benefit, especially in older kids, but they do increase motor blockade, so you have to use this with judicious judgment. So how do you determine how much local one can use? Well, bupivacaine, again, is the most commonly provided concentration of 0.25%. So how do you calculate the maximum allowable dose for a 10 kilogram baby? Well, you take the maximum allowable dose of 3 milligrams per kilogram. So that equals 30 milligrams for a 10 kilogram child. At 0.25% bupivacaine, that equals 2.5 milligrams per ml. So therefore, the maximum allowable dose for this child is about 12 milliliters. That will equate to 30 milligrams. However, it's hard to remember all of these equations in mind. So a good quick calculation to remember that I use is with 0.25% bupivacaine, you can use 1 ml per 1 kilogram. And this will keep you under the maximum allowable dosage. So that will give you approximately 10 milliliters for a 10-kilogram baby. Oftentimes, you could also use adjuncts to local anesthetics, and this is sometimes used by the anesthesiologist when they give caudal blocks. There are some potential benefits for adjuncts. They can increase the duration of the anesthetic action. It allows for a dose reduction and allows you to use more without exceeding the maximum allowable dose. And oftentimes, it can be used as a tracer to see if there is any intravascular injection. So the most common one, especially as the test dose, is epinephrine. It is the only adjunct that is added routinely by the drug manufacturers themselves. It is typically used as a test dose to identify inadvertent intravascular injection. And so what they're monitoring with this test dose, especially with caudal blocks, is reaction to epinephrine, heart rate changes, EKG changes, systolic blood pressure changes. It overall has little effect on prolonging the action of durations for these long-acting anesthetics. And there is some concerns because there have been case reports of devastating neurologic complications when you actually inject epinephrine into the epidural space. So this should be used with caution. Clonidine is a common agent that is used as an adjunct. It tends to extend the duration of local anesthetics by up to 4 hours. Higher doses, however, are associated with an increased risk of sedation, bradycardia, and hypotension. So it's typically not recommended in very young children, less than 3 months of age. Its effectiveness in peripheral nerve blocks are much more controversial, and they may not be as beneficial and may increase the risk of motor blockade as opposed to being used as an agent in caudal blocks. Speaking with our anesthesiologists, most of them do only use clonidine when they're thinking of using infusions rather than single-dose caudal blocks. So what is the fear of using these agents? Well, the ultimate fear is the LAST syndrome, which is a local anesthetic systemic toxicity. So this constitutes, in the most severe cases, severe CNS and cardiovascular effects, which are listed here. The proposed mechanism is that it prevents the fast inward sodium channels in the myocardium from opening. And to prevent this, strategies are to adhere to the maximum allowable dose, avoidance of intravascular injection, and avoidance of conditions that can exacerbate anesthetic toxicities, such as hypoxemia, hypercarbia, and acidosis. So how common and how safe are pediatric blocks? So this is a slide courtesy of one of our pediatric anesthesiologists at Lurie Children's Hospital. And it's data from the PRAN network, which is an anesthetic organization of regional anesthesia, where they log all the blocks. And as you can see here, there has been no cases in over 100,000 pediatric blocks of permanent neurologic deficit. There's been 25 cases of transient neurologic deficits, and the last rates are as low as 0.76 per 10,000 individuals. And as you can see here, with the different types of blocks, caudal block tends to be on the lower side of being at risk for complications. But it can occur. And in this slide, also from Dr. Shaw, shows that in the last 7 reported incidences of LAST, 3 out of them were caudal blocks. These were done by landmark techniques using a combination of either ropivacaine or bupivacaine, and they were associated with severe symptoms such as seizures and cardiac arrest. However, when you look at the risk factors for it, it seems like the risk factor at greatest risk for LAST is in infants under 6 months of age. There's been 11 additional cases of mild LAST syndromes that were reported in this database, all resolved all were in the postoperative period and all resolved without further sequelae. So now we'll talk about the individual regional blocks. So we'll cover the caudal block, the TAP block, the pudendal block, the ilioinguinal iliohypogastric nerve block, the dorsopenile nerve block, and the spermatocord block. So some of these are commonly performed by the pediatric anesthesiologist, the caudal, tap, and pudendal block. Some pediatric pediatric urologists will also perform a pudendal block, but more commonly, the ilioinguinal, iliohypogastric, and the dorsopenile nerve block are commonly performed by the pediatric urologist. So the caudal epidural block is probably the most commonly used and widely used nerve block, especially in pediatric urology. It involves placing a needle through the sacral hiatus to deliver medication to the epidural space. We'll show the anatomy in a second. It provides excellent analgesia all the way up to the level of the umbilicus. It's easily learned by the anesthesiologist and tends to have high efficacy. There are contraindications to the caudal block. Of course, parent or patient refusal, infection at the injection site, not the infection site, increased intracranial pressure, local anesthetic allergy, coagulopathy, known spinal bifida, but also concerns about a tethered cord. And so one of the more common ones that we will encounter in our practice would be the identification of a sacral dimple. And sacral dimples are controversial in terms of which ones are concerning and which ones would be benign. And this was an example of a recent patient of ours who did receive a caudal block because he was appropriately evaluated with an ultrasound prior to surgery, which did not show evidence of a tethered cord. So this is a dermatome distribution of the caudal block, showing the importance of the concentration to the level of the block. So here's the start of the block. If you want to just keep it within the sacral area, you would use a lower concentration, 0.5 mLs per kilogram. If you want to reach all the way up to the umbilicus, you'll use a concentration of 1.25 mLs per kilogram. So here is the anatomical basis of the caudal block. And so this is the sacrum, the coccyx. The two landmarks that the anesthesiologists use are the sacrocornuous, entering into the sacral hiatus. And this is where they'll inject the local anesthetic. When the child is laying in the lateral position, they feel for the posterior superior iliac spines. They make a triangle and feel the cornuous, and in that area is where you'll find the sacral hiatus. Is there a age limit for caudal epidural blocks? There is, and it is individualized by the pediatric anesthesiologist. But what needs to be considered is the ambulatory status of the child. Most of the time, you'll get mainly sensory block, but there is some motor blockade associated with caudal blocks. So you want to make sure that the child is at least light enough that their caretakers will be able to support them, at least in the early perioperative period, in case they do have motor weakness. As the older you get, the more calcified the bony landmarks become, and it becomes more difficult to access the sacral hiatus. And there is a maximum accepted dose for a single shot caudal. So to reach the level of the umbilicus, you need to inject 1.25 mLs per kilogram as your maximum. So the maximum accepted dosage is about 20 mLs. So that equates to roughly about a 16 kilogram child being the upper limits of where most anesthesiologists would feel comfortable in doing a caudal block if their goal is to reach up to the umbilicus. Of course, if your only goal is to reach near the sacrum, you can extend the weight limit as you would be using less mLs per kilogram. So how safe are caudal blocks? This is an observational study of 18,650 children using that same PRAN database. What they found is the incidence of complication being 1.9%. There was an increased risk in complications in younger patients. So this by itself, it shows that it's very, very safe, but it does raise some concerns. So what were their most common classified complication? So you can see here, the most common one is actually a block failure. So one without sequelae and not of too much concern, besides the fact that your block failed. The other ones, which are more scary, the blood aspiration, the dural puncture, cardiac arrest, seizures, these are much lower in terms of the incidence and complications. And it's important to note that they reported no temporary or permanent sequelae from these complications. So how effective are caudal blocks? Well, these are early studies which looked at inguinal hernia in Conroy et al. In Journal of Pediatric Surgery. And what they found was that caudals did significantly decrease the time to emergence and required less narcotics when compared to local wound installation of local anesthetics and those who were treated mainly with opioids. Langergand et al. In Urology 1994 looked at general anesthesia alone with caudal block and with local anesthetic, and they found that caudal block and the local anesthetics led to lower pain scales and lower pain medication necessary in the PACU as compared to general anesthesia by themselves, showing that there is a benefit. This was looking specifically at caudal block's effectiveness in terms of pain control for hypospadias, and published in the Journal of Pediatric Urology 2018. A randomized trial of general anesthetic with caudal block versus general anesthesia alone. As you can see, with caudal blocks, they had a decrease in operative time, a decreased need for fentanyl use in during the surgery itself, and they actually showed that the estimated blood loss was lower in kids with epidurals as compared, or caudal epidurals, as compared to those with general anesthesia alone. This study looked at—
Dr. Liu, there is a question kind of related to this topic in the Q&A. It's asking, do you use peridural catheters during severe hypospadias surgery?
Oh, caudal epidural.
An epidural catheter.
Oh, we typically do not. Most of the time, our anesthesiologist will do a caudal block at the beginning of surgery. And this is another instance that they would use clonidine, because then they can decrease their total use or administered dose of ropivacaine at the beginning. And then if the surgery is longer than 3 hours, then at the end of the procedure prior to emergence, they will repeat the caudal. And so we usually don't leave a long-term catheter in. Some anesthesiologists do prefer placing the caudal catheter in so they don't have to re-stick them twice. And then after the injection before emergence, then pulling the catheter out. All right. Does that answer the question?
Yep.
Yep, okay. All right, so this study was out of Indiana, and this looked at a retrospective cohort studies of boys under 10 years of age undergoing all penile surgeries from 2013 to 2015. And they looked at the combination of the FIS database as well as the PRAN database, as well as their own. And they compared caudal blocks with dorsopenile blocks and looking at pain scales. And what they found here was, again, a benefit of caudal blocks over dorsopenile nerve blocks alone in terms of cumulative narcotics and morphine use, intraoperative narcotics, and need for intraoperative antiemetics. And in the PACU, they also did show a benefit in decreasing pain scores and the use of PACU narcotics. However, they did conclude that from a cost standpoint, it seemed to be unclear because it was much more costly as compared to a dorsopenile nerve block on its own. This study is in press, but I did find it in the Journal of Pediatric Urology that sort of contradicted the previous articles. This one looked at caudal epidural blocks versus ultrasound-guided dorsopenile nerve blocks for distal hypospadias. And it was a prospective observational study. And what they found in this study was that there were higher pain scales and a higher need for postoperative analgesics with the caudal block as compared to the dorsopenile nerve block. So sort of contradictory to the Indiana series. Now, what could explain that? Well, it could be also There has been some debate, not clearly shown in the literature, of whether ultrasound-guided blocks are better than landmark-guided blocks. So that leads us to the point that if you do accept that caudal epidural blocks are beneficial from a pain standpoint, are there any negatives to using a caudal block for hypospadiasis? And this was really a debate kicked off by this article by Kundra that looked at a double-blinded randomized study of 54 boys undergoing distal hypospadias repair between caudal blocks as well as penile blocks. And their main goal was to look at intraoperative and postoperative pain control. And what they found was that in their study too, they did not find that caudal blocks were superior, but in fact found it to be inferior to the penile nerve block. However, what they also found was on subsequent analysis and follow-up, the 4 ureterocutaneous fistulas that were presented in their groups all came from the caudal block. They speculated that the caudal block increases penile blood pooling by decreasing the activities of the sympathetic nervous system, and therefore could lead to increased penile edema and impaired wound healing. And they did penile measurements to further support their argument. Subsequent to that, there was many follow-up studies done from multiple institutions, mainly published in the anesthesia literature, that shared similar results from retrospective studies. This one out of Korea, looking at 388 patients with an increased complications with caudal. A study out of Duke, which also looked at a single surgeon retrospective review that also did find an increased incidence of complications with caudal block. And lastly, the most recent one showing another single surgeon retrospective review and an increased risk of ureterocutaneous fistulas associated with caudal blocks. On the contrary, you also did have many articles coming out that showed that there was no association. This one out of Michigan, which did a single center retrospective review and found no association, but found associations more with the location of the meatus, prolonged OR time, and use of epinephrine. This study also showed that that there was no increased risk of complications with caudal block versus penile block versus no blocks alone. And again, the type of repair and the severity of the hypospadias seem to be more contributing factors than the presence or absence of the caudal block. And lastly, this study by Braga et al. Was also a single center retrospective review of the TIP procedure, looking at caudal blocks versus dorsopenile nerve blocks. And on multivariable analysis, showed no association with the caudal block in terms of complication. And they only found an association with the meatal location. So where do we make of all of this literature? So this was a meta-analysis done out of Dr. Braga's group, looking at the 9 studies that are out there. And unfortunately, all of the studies out there are still of low or moderate quality. And so there's a lot of variabilities in these study groups. Some have only isolated them to distal hypospadiases. Other ones have included all forms of hypospadiases. Some studies have included the injection of epinephrine, which some believe is the culprit in terms of the increased complications rather than the caudal block, while others have excluded epinephrine injection too. And so when you look at these 9 studies and they looked at the pooled data, they did show that there was a higher rate of complications with the caudal group when they adjusted for everything, but it was a mild effect, as you can see from the forest plot here. However, when they did do subgroup analysis and looked at hypospadias severity, they found that it played an important role in these studies. So the ones that did include proximal hypospadiases strongly favored the control group, lack of caudal epidural block, while if you isolated ones that only looked at distal hypospadiases or only looked at distal hypospadiases, you found that there was a lot less significance to the risk or the odds ratio. So they concluded that although their data did show that there may be an increased risk of complications with caudal epidural blocks, that hypospadias severity was a very important intervening factor. And the jury, I think, is still out in terms of whether caudals increase hypospadias complications, and really calls for the need for a randomized controlled trial to try to answer these questions. So what are the other options that are out there if you don't want to use a caudal block? You have a transverse abdominis block. This is a tap block. It's performed to try to block the thoracolumbar nerves T8 to L1, including the ilioinguinal and iliohypogastric. It's useful for abdominal wall surgeries and laparoscopic surgeries and umbilical hernia repairs. The downside is it doesn't provide a good, reliable level of anesthesia, and it doesn't necessarily prevent visceral pain, especially when you have a laparoscopic procedure. So the technique is typically done with ultrasound guidance. You start off at using ultrasound, identifying the rectus abdominis, and then moving laterally past this muscle until you identify the three layers on the external oblique, the internal oblique, and the transverse abdominis. And the injection is between the internal oblique and the transversus. So this is an image showing the injection site. So what is the usefulness of the tap block? Well, it plays an important role with patients with spinal bifida. So our center was the first one to report the successful use of bilateral tap blocks in 2 patients that had spinal bifida, remembering that spinal bifida would be a contraindication for caudal. So these were patients that were undergoing appendicovesicostomies, and they showed that it was successful in helping to decrease the need for postoperative pain medication. In terms of laparoscopy, the literature is more variable. So this, looking at tap blocks versus no tap blocks for lap appies, showed no significant difference in postoperative analgesic use. A study out of our own center compared caudal epidurals with tap blocks for robotic-assisted laparoscopic surgery. And again, in this, showed that there was really, the tap block was inferior compared to the caudal block. And so these are the study dynamics here. The pudendal nerve block has been raised as a possible alternative, especially for hypospadias repairs. So the pudendal nerve rises from S2 to S4. It enters into the perineum via the lesser sciatic foramen and travels in the pudendal canal. This is also known as Alcott's canal. It splits into the perineal and the inferior rectal nerve, which then becomes the dorsal nerve of the penis in the male and the posterior scrotal nerve. It provides motor and sensory innervation to both the genitalia as well as the perineum. So the pudendal nerve block is also typically done with ultrasound guidance, but can be done by landmarks too. It's performed in the lithotomy or the frog-leg position, as demonstrated in this picture here, identifying the ischial tuberosity and injecting in this site here. The need is to carefully avoid the pudendal artery, which runs in this general area, to avoid an intravascular injection. So how well does the pudendal nerve block works? So there is a 2 prospective double-blind randomized trial that looked at the pudendal nerve block versus the caudal block for hypospadias repairs. And both of them tended to favor the pudendal nerve block. So this is Naja et al., looking at 80 patients undergoing hypospadias repair using the assistance of a nerve stimulator, so not using the ultrasound. What they found was that parental satisfaction was higher in the pudendal nerve group. The need for analgesics within 24 hours was also improved in the pudendal nerve block group as compared to the caudal. And the amount of analgesics consumed by the patient was also less with the pudendal nerve block group. Pain scores were ultimately lower in the pudendal nerve block group. Another study, this looked at 84 patients, again, a mixed group of hypospadias repairs, also done with the assistance of a nerve stimulator, and compared them to the caudal epidural block. And what they found here was that there was a benefit of the pudendal nerve block, but the pain scores here was mainly seen at 6 and 12 hours, where the caudal epidural seemed to have worn off and had higher pain scores. And so they postulated too that there was an advantage to the pudendal nerve block. Here is another graphic showing the time point. As time went on postoperatively, the pudendal group was better. Hecht et al. In the US, in the urologic literature, published a single center, single surgeon series using ultrasound guided pudendal nerve block and compared it against caudal epidural block, and actually found that there was no difference in the need for intraoperative opioid requirements or the amount of postoperative opioids or non-opioid analgesics. The only difference was in the postoperative length of stay, being that the pudendal blocks were discharged sooner as compared to the caudal block. However, this study did have marked differences in terms of patient age and severity of hypospadias between the two groups. So does the ultrasound help with identifying and performing the pudendal nerve block? So this was a QI project. This is also in press at the Journal of Pediatric Urology, looking at caudals versus ultrasound-guided pudendal nerve blocks versus landmark-guided pudendal nerve blocks, looking at outpatient pediatric penile surgeries. What they found that there was no mean difference in terms of PACU scores among all these patients or length of stays, and found that there was no complications reported in any of the groups, suggesting that landmark-directed pudendal nerve blocks can be sufficient and does not require ultrasound guidance. The ilioinguinal iliohypogastric nerve block is probably one of the more common ones that we as pediatric urologists use. This is blocking the nerves that arise from L1. The ilioinguinal nerve innervates the anterior surface of the scrotum and the labia, the root of the penis and the mons, and the upper anteromedial thigh. It has motor innervations to the internal oblique and the transversus abdominis. The iliohypogastric is sensory to the skin in that general area and the hypogastric area, and has also some motor function to the internal oblique and the transversus abdominis. So there's 4 landmark techniques that are described in the literature. This one looking at drawing a line between the ASIS and the umbilicus and injecting it a quarter of the way through that line. Another one is sort of at McBurney's point, looking at 10 millimeters medial and 10 millimeters inferior to the ASIS. One looking at similarly, but going higher up, because if you remember, the course of the nerve will come around and loop around the ASIS. So you're trying to inject where the nerve is entering into the inguinal area. This one goes higher up. And the one I prefer using is about 10 millimeters medial to the ASIS. And I go at a 45-degree angle against that bone and then withdraw it into the fascia to inject in that area. So do landmark techniques work? Well, we all think it does, but in reality, we may not be so sure. So this was a study looking at the position of the ilioinguinal nerve using ultrasound. And so what they did was they took 200 children in different age groups, splitting them into 3 groups, and then did measurements of the nerves to the ASIS, as well as to each other, and as well as to the skin and the perineum. And what they found was that there was great variability in terms of the location of these nerves to the ASIS dependent on your age group. And so they do advocate that you take that in mind or to use ultrasound guidance. However, there was no difference in the level between skin and the nerve as well as the nerve to the perineum. So this is a schematic looking at an ultrasound guided block. You place the ultrasound probe medial to the ASIS, oriented towards the umbilicus. You again will then visualize the 3 main muscle groups, and you want to inject again between the internal oblique and the transversus abdominis. There are potential complications of this block. One is, of course, intravascular injection. Another is if you go too high, there is concerns that you can then hit the bowel and cause injury to the bowel. Another similar concern would be with the tap block. You can get a hematoma, and you can have a transient femoral nerve palsy. And this has occurred in my own career once or twice. This is associated with temporary sensory loss to the anterior thigh and weakness of the knee with reduced power to that limb. It's postulated that this occurs if you inject too large of a volume in the fascial plane, and it tracks down towards the iliacus, which then will temporarily block the femoral nerve. The good news is it's temporary, and it will resolve in 4 to 6 hours. But as you're going to understand and recognize, when it does occur, it does cause some considerable distress, both to the surgeon as well as to the patient and their family. So how efficacious is this block as an adjunct to caudal block? So this study investigated it as an addition in a double-blind randomized controlled trial in patients undergoing inguinal hernia repair, hydrocolectomies, orchiopexy, and orchiectomies. And they did find a significant decrease in pain scores when you combine both the caudal block as well as the ilioinguinal nerve block as compared to caudal alone. But this was only seen in the inguinal herniorrhaphies. It did not seem to make a difference with the orchiopexy or orchiectomy. Could be secondary because of the, at least with the orchiopexy, to the secondary incision in the scrotum. But it's difficult to know exactly why they did not see this difference. This study in anesthesia in 1987 looked at unilateral orchiopexy alone and comparing caudal versus ilioinguinal blocks alone versus no blocks at all. And they actually found that there was no significant pain differences between caudal and the ilioinguinal nerve block. And both those two blocks did have lower pain scores versus the control, but did not reach statistical significance. However, the control group did receive more fentanyl in the PACU as compared to the block group. Fredrickson et al. Did a study looking at ultrasound guided TAP versus ultrasound guided ilioinguinal iliohypogastric nerve block in that same type of patient with groin surgery, and they found that the TAP block was inferior to the ilioinguinal and iliohypogastric nerve blocks. So there was a systematic review and meta-analysis published in the Medicine Journal in 2019, which looked at 6 studies with 632 patients, looking at the TAP block versus the ilioinguinal iliohypogastric nerve block, and found that there was actually no statistical significance favoring either of the two groups. However, the ilioinguinal iliohypogastric nerve blocks did tend to have statistically significant improvement in pain scores, but only at the 6 and 8 hour postoperative period. Penile nerve block, this is probably one that we're very familiar with. It is to block the dorsal nerve of the penis, which again is the branch of the pudendal nerve. Innervates the distal 2/3 of the penis and lies within Buck's fascia. This can be achieved in a number of different ways, including a subcutaneous ring block, as shown here. A subpubic block, where you pull the penis downwards and you go right underneath the pubic symphysis into the fascial plane. I was taught to bounce the needle, and if the penis will bounce with you, that's the proper plane to inject into. Or you can do a dorsal nerve block, injecting around the 10 and 2 o'clock position in a similar type fashion. So one question that comes up is epinephrine safe for a penile block? And so there was a case report in 1990, which was a 2-day-old undergoing a circumcision. A dorsopenile nerve block was being performed, but got injected with epinephrine accidentally instead of lidocaine. So no local anesthetic, but just epinephrine on alone. And the child then displayed systemic effects from this, getting a molten appearance with bradycardia, and the penile shaft and suprapubic areas appeared pallid, and the glands became hyperemic without blanching. They performed an emergent caudal block as an anti-sympathetic effect and found that they did have improvement within 18 hours with no permanent sequelae. But this questioned and brought up the concerns of using epinephrine in penile blocks. However, this recent study out of the German literature in 2014, looking at both adult and pediatric patients, they took 95 patients undergoing circumcisions, performed a penile nerve block using either ropivacaine and lidocaine mixed with or without epinephrine. They were all injected with epinephrine in either the 0.11% solution or the 0.21% solution. What they found was that there was no reported complications and high patient satisfaction, questioning whether epinephrine is truly contraindicated in a penile nerve block. So what is the efficacy of the penile nerve block? Well, it seems to be very effective, especially for circumcisions. This study, Brodmann et al. In anesthesia in 1987, blinded prospective study of 50 patients undergoing circumcision, found that less fentanyl was needed overall. They had lower pain scores and quicker time to discharge. This JAMA article looked at ring blocks versus dorsal nerve blocks versus topical anesthesia alone in newborn circumcisions. And what they found was that the EMLA cream, the topical anesthesia, was the least effective. That both the ring block and the dorsal nerve block were equivocal, except during skin separation and incision, which actually favored the ring block. This advocated for people and providers who are not as comfortable with the dorsal nerve block to do the ring block, as it is considered a safer type of block. Here was a randomized controlled trial looking at this exact same population, 70 neonates undergoing clamp circumcision, divided into 4 groups: an EMLA cream group alone, EMLA cream with sucrose, EMLA cream with sucrose and a dorsal nerve block, as well as a 4th group looking at EMLA cream, sucrose, and a ring block. And they looked and divided the neonatal clamp circumcision into 6 stages: the stretching and clamping of the foreskin, the dorsal slit, the lysis of adhesions, the clamping of the clamp, cutting of the foreskin, and application of the dressing. And what they found here is, as you can see here, overall, the regional blocks had an advantage over the non-regional blocks, and sucrose did have an advantage over EMLA itself. In particular, you do see that the local anesthetics did seem to be very much superior as compared to the non-regional blocks at the 4th stage, which is the application of the clamp. When you looked at heart rates and crying time as an indicator of pain, you saw that same type of advantage using local blocks. And overall, it seemed like the ring block was favored over all of the other ones, being that the ring block was more superior to the dorsal penile nerve block. Does ultrasound guidance then increase efficacy, or is landmark techniques that most of us use alone okay? So this was a study that was a prospective randomized trial looking at that question. And what they found that in terms of the use of fentanyl, there was no statistical difference between landmark-based techniques versus ultrasound-based. And in terms of the time to perform it, as you can imagine, the anatomical placement was better. However, the number of kids that required coding in the PACU was higher in the anatomical landmark-based group as compared to the ultrasound-based group. So sort of a mixed message here in terms of whether ultrasound should be used in the performance of this nerve block. So the last block we'll be discussing is the spermatic cord block. It blocks both the ilioinguinal nerve as well as the genital branch of the genital femoral nerve, provides innervation to the cremasteric muscles in the scrotum. It is typically performed as a land-based technique 1 centimeter below and 1 centimeter medial to the pubic tubercle. Where you grasp the cord, you provide some traction, and you inject the spermatic cord, taking great care to aspirate to prevent intravascular injection. I think this is the block that most urologists are most comfortable with, as it's commonly performed in the adult setting. You can use an ultrasound guidance also, and if you do, you're going to place the ultrasound probe sort of in the groin, right in the midway point between the pubic tubercle, where you would imagine you would make your incision for an orchiopexy or herniorrhaphy. And what you want to try to then image is the vasculature as well as the spermatic cord, and injecting directly into the cord itself, avoiding the vascularity if you can. So the last topic we'll briefly talk about is the use of Ketorolac, or as a non-opioid analgesic alternative, especially perioperatively. And so Ketorolac, as you are probably familiar with, is the only available parental non-steroidal anti-inflammatory that's approved. Its mechanism of action is to prohibit the production of prostaglandins through the inhibition of COX-1 and COX-2. And it is non-selective, so COX-2 is mainly the effects that we desire, decreasing inflammation, pain, and fever, while COX-1 is the negative effects, its effects on the GI mucosa, platelet aggregation, as well as possible effects of renal function. The side effects are bleeding complications, probably the one that's most concerned to pediatric urologists in trying to answer that question of should Ketorolac be used. But it can also have these other concerns. It's recommended that we use it no longer than 3 to 5 days of continuous use, mainly because of concerns of the GI effects. So are there safety concerns associated with it? Well, in overall, the pediatric literature, there's many studies that have looked at and demonstrated the safety of Ketorolac in surgeries ranging from tonsillectomy and adenoidectomies to scoliosis and neural surgery. Nassim et al. Looked at a FIS database of children between 5 and 17 years of age who underwent appendectomies between 2010 and 2014, and 73% of these did receive Ketorolac. And what they were looking for is whether Ketorolac can decrease complications and be associated with lower costs. And their multivariate analysis did show a benefit of Ketorolac without any negative in terms of association with readmissions, postoperative length of stay, or postoperative infections. How about in the pediatric urology literature? So it's mostly studied in ureteroneal cystotomies. First published by Gonzalez and Smith in 1998, looking at a retrospective review of 43 patients who underwent ureteroneal cystotomies. And these were both intravesical and extravesical approaches. 23 received Ketorolac and 20 received narcotics. And what they found in their study was a decreased length of stay within the Ketorolac group. Study by Park et al. In 2000 was a double-blinded randomized study looking at Ketorolac versus placebo in intravesical ureteroneal cystotomies. And they looked at 24 patients, all had epidurals, and then they administered Ketorolac every 6 hours for 48 hours post-op. And what they found was that there was a significant reduction in bladder spasms, number of spasms per patient, as well as the severity of bladder spasms. And there was no adverse effects reported. This was actually planned to be a much larger study, but was stopped early because of the clear benefits of Ketorolac in terms of decreasing bladder spasms. Chana et al. In 2001 also did a retrospective review looking at Ketorolac with Caudal versus Caudal with narcotics. And they demonstrated again that there was no significant difference in postoperative hematocrit or creatinine, demonstrating that it was a safe use in these patients. So demonstrating that it is effective and safe, how often is it actually used? A study by Ruth et al. In 2010 looking at the FIS database shows that only 52% of eligible patients receive Ketorolac, in their groups using undergoing ureteral neocystotomies. They tended to be older kids, females, as well as having decreased disease severity. And what they found in this large database is that there is an advantage using Ketorolac with a decreased length of stay and a decreased overall cost without a significant difference in complication rates. And again, the study by Morrison et al. Shows that when you survey pediatric urologists, still a good number, 14% of those survey respondents state that they do not use Ketorolac in their postoperative patients, which then goes to question of what is the concerns, as the literature seems to demonstrate good safety with Ketorolac. How about for penile surgery? And this is probably one of the more common surgeries we perform, and one in which Ketorolac is often questioned of whether it's safe to be given or not. So this was a retrospective review that looked at a single center for circumcisions. And this study did show an increased return to ER for bleeding in patients who did receive Ketorolac. However, our own study, which we presented at the SPU in 2019, using the FIS database of all penile outpatient surgeries, including circumcisions, chordee repair, hypospadias, and penoplasty. And in this study, we found that only 14% of these children did receive Ketorolac. But when you compared them with the patients who did not receive Ketorolac, there was no association of an increased need to go back to the ER or for any reason, and there was no association for return for bleeding complications, leading more, I think, evidence that Ketorolac should be safe. So in conclusion, numerous neuraxial and peripheral nerve blocks are available as adjuncts to improve perioperative analgesia in pediatric urology, many of which can be learned easily by the pediatric urologist and utilized as part of their practices. However, the true efficacy and safety of some of these blocks remain in question. The biggest answer of whether caudal blocks do affect hypospadias complications, and we eagerly await, hopefully, results from randomized control trials to try to better answer this question. We do know that Ketorolac does appear to be very safe and efficacious, at least for ureteral neocystotomy, and it does seem to be promising in other outpatient urologic procedures, including penile surgeries, where the risk of bleeding complications may be unfounded. However, overall, I do think that well-designed and randomized trials are still required to better answer all these questions. So thank you very much. A special thanks to Ravi Shah, one of our pediatric anesthesiologists, who was instrumental in helping me design this talk. Here's my email address if anybody needs it for any questions that doesn't get answered tonight. And we hope that you will share your thoughts with us by taking this survey. The QR reader is as displayed. Any questions that still remain?
Yeah, there's one other question here in the Q&A. It's in regard to Ketorolac. Is there a similar effect with ketoprofen, which is a non-steroidal anti-inflammatory oral agent?
I'm not familiar with that agent alone. I know in terms of oral agents, we do routinely use Tylenol and Motrin as alternating doses for outpatient penile surgery. Similarly, most of our practice and most of the studies that I've reviewed, typically with robotic and laparoscopic procedures, tend to place patients on that alternating Tylenol and Motrin regimen and has not seen or demonstrated any adverse effects of it. But that agent alone I cannot comment on. All right, well, I'd like to thank you guys for your attention. And again, please email me if you have any other questions.